Krishna, we are live now. You can start.
Okay, thank you, sir. Hello, good afternoon, everyone. This is Krishna Kansara, and on behalf of the ForOptom team, I would like to welcome you all for this session, starting with a short introduction of an e-learning program for students, which is initiative by the ForOptom team, where optometry-related topics are discussed and interacted briefly. The session is streaming live, and if you have any queries regarding the topic, you can let us know in the chat section. We will be discussing them after the presentation. Before starting the session, let me introduce our today's speaker, Ms.Bavarva. She is a third year student of Bachelor of Optometry from Jyot College of Optometry, Navsari, Gujrat. She will be presenting on pseudomyopia and its management. On behalf of the ForOptom team, I welcome you, Priya. Over to you now.
Thank you so much, Krishna, for giving a short intro. So now we'll start my topic. After having such informative learning in all online session, I was a little hesitate to present my topic, but nevertheless, it is as important as anything else in optometry. I feel we can survive without knowing some advanced topic, but without this basic, we all are in danger zone. So today our learning objectives of my presentations is what is pseudomyopia, clinical features of pseudomyopia and diagnosis, case analysis and management of pseudomyopia. So as we all know, when we see the near object, our eye start accommodations, and when we see the distance object, our accommodations become in relaxed position. So the accommodations is a dioptric adjustment of the crystalline lens for a to obtain a clear vision for a given target. This is thanks to contractions of the ciliary muscles and relaxations of sonule. So what is a pseudomyopia? So the pseudomyopia is the process of increasing the plus refractive power of the crystalline lens, particularly for the viewing closer objects. So due to the accommodations, the power of crystalline lens is increases on plus side. So and in rare instance, accommodation does not relax even when viewing the distance object due to the plus refractive power. Lens is unable to relax their position, and the lens is stuck in their position. That's why patient is not able to relax their accommodation for distance, and then patient sees the distance blur vision. The such patients are said to have accommodative spasm and typically exhibit increase the myopia or decrease the hyperopia. The pseudomyopia also refers to a accommodative spasm, hyperaccommodations, and ciliary spasm. A different examiner give the different names. Some says accommodative spasm of muscles, including the eye muscles, and drugs like antihypertensive drug, for example, hydrolyzine hydrochloride, and a thermal drug can increase the power of the lens so that the light rays come to a focus in front of the retina. And overuse of eye for the close work in poor or glaring lighting can also cause the pseudomyopia, like diamond workers and computer workers and etc. And sudden nearsightedness in an adult or rapid worsening of the nearsightedness is like to be a pseudomyopia, and pseudomyopia symptoms is same as the myopic symptoms, but the pseudomyopia usually clear up when the underlying cause is treated. So the here increased use of digital devices nowadays, it is the biggest cause of pseudomyopia. Due to the lockdown scenario, the use of digital devices has increases. So due to the excessive use of the devices, the accommodation is increases. So the accommodations related issue also increases. So there is more accommodation. So the chances of pseudomyopia get is increased. So the here due to the lockdown device used get increase. So here pseudomyopia is just because of the excessive use of digital gadgets, so we can call it as a fun myopia. And sign and symptoms of pseudomyopia. So first sign is a blurring of intermediate and distance vision after the prolonged use of near work. This is the main symptoms of pseudomyopia. And headache and eye strain, the patient is feel the headache and eye strain after the continuous near work. And the esotropia, as we all know, when accommodation in and the convergence is act like a twin sister. When accommodation is increases, the convergence is also increases. So in pseudomyopic patient, isotropia is also present, and photophobia, light sensitivity, and diplopia due to the isotropia or isophoria. Patients may feel the diplopic vision, and other either patient having a convergent spasm, or patients also feel the diplopic vision. So now, which investigation we carried out in pseudomyopic patients? First, history. Take the patient history in detail. Due to in current scenario, ask the patient how many hours you use the near work, and how many hours you do the hour you spend on digital works, and then take a detailed history like birth history, family history, and systemic history. And if patient complain of inward rotation, of I ask the patient on time when you first time notice, and after taking the history, you take a vision unaided and aided for both in distance and near. And after performing the vision, you perform the objective refractions and subjective refractions. After perform the subjective refraction, and you perform the accommodation related based binocular balancing related test, duochrome test. And after perform the duochrome test, you put the cycloplegic eye drops according to patient's age, and after dilatations of the eye, you perform the objective retinoscopy. And after retinoscopy, you again perform the subjective refraction, and you get the final answer of the patients, which amount of refractive error is patients having. So which other test is required for the pseudomyopic patients? These all are the test is required for the pseudomyopic patients. Here the accommodation is divided into accommodations amplitude, accommodation facility, and indirect measurement or indirect response of accommodations measure with the MEM technique and NR and PRA techniques. So we will discuss about all these procedures. So we first discuss about the accommodative amplitude. Accommodative amplitude is dividing it measure with the three technique. First is the push up, and the second is pull away test, and third is minus lens technique. But in clinical, most acceptable is a push up test. So what we do in push up test, first ask the patient to fix the target, and keep the target away from the patient eye, and instruct the patient, when you see blur, you inform me, and then you move the target toward the patient's eye, and patient says it is blur, and then ask the patient to blink your eyes, and patient say now it is clear, to move your target more towards the patient side, and then patient says now it is blur. Then measure the distance between the target and the patient's eye, and you get your answer, and then your answer divided by 100, you get the value of amplitude. And your value is compared with the Hofstadter formula, Hofstadter normative average formula, is 18 minus 0.3 into age, and you compare the what amount of amplitude is required for the in this age. And our second method is monocular accommodative facility. In monocular accommodative facility, what we do, we ask the patient to occlude her one eye, and ask the patient to hold the near vision chart at 40 centimeter, then put the and then select the flippers according to the patient, and put the plus lens side first in front of the patient eye, and put a timer of 1 minute, and ask the patient, when you see clear, tell me, and then you flip your flippers and measure the cycle. And here the normal expected value is 11 cycle per minute. If the patient is difficulty in plus size, so patient having accommodative access or insufficiency, and in patients having difficulty in minus size of patient is in okay. And other test is the indirect test. Why MEM is the indirect test? Because in this test we ask the patient to look binocularly. That's why patient's version is also present in at that time, and we indirectly measure the accommodation. That's why the MEM is the indirect test. What we do in MEM test, and MEM test required is the MEM MEM card, and he attached with the retinoscopy and trial frame and trial set, and we ask the patient to fix the target on the MEM card and instruct the patient to read the word on the MEM card and measure the distance from patient 40 centimeter, and then examiner perform quickly retinoscopy, and if patient see the minor with movement, you put the plus lenses, and patient sees against movement, put the minus lenses, and try to neutral the globe. But here one thing is, remember, you should not keep the lenses in longer period of time, because the plus lenses is relax the accommodations and the minus lenses is stimulate the accommodation. That's why we not keeping the lenses in front of the patients a longer period of time. Okay, and expected, when normal expected MEM value is plus 0.20 25 diopter to plus 0.5 diopter. If your reading is more than plus 5 diopter, means patients having a lack of accommodations, and if your reading is on plano side and minus side, means your patient is a lead of accommodations. And our next method is the NRA and PRA. How to perform NRA and PRA? First, put the subjective corrections in trial frame, and then ask the patient to hold the near vision chart at 40 centimeter, and instruct the patient to fix the target N8. Why N8? Because we always give the above one line, then the best corrected visual acuity. Okay, if the patient's visual acuity is N6, we give the N8 target. So, and then we always first perform NRA and then perform PRA. So over the subjective correction, put the plus lens in NRA, put the plus lenses in 0.25 diopter step until the patient reports the blur, sustained blur. And in PRA, and then perform PRA. In PRA lenses, put the minus lenses in 0.25 diopter step until the patient's reports sustained blurs. Here our expected NRA value is plus or minus 2.5 diopter. So here is accommodative flippers, and the MEM. Here it is MEM cards. The MEM cards is available in different, like a picture for children, is available in pictures cards. And now next test is the Borish delay subjective. Borish delay subjective test is not for the accommodative spasm test, but it is described for the accommodative access patient. For example, if the patient having a complaint of headache and eye strain, and you get the answer of retinoscopic answer is +3. But whenever you perform the normal fogging test and patient accept the +1, and you try to put 1.5 diopter in front of the trial frame, patient says now it is a blur. In this case, this technique is work, because the on normal fogging, it is patient is not able to relax their accommodation. So in these cases, we perform the Borish delay test. So what we do in Borish delay test, first perform the objective and subjective relaxation, subjective refractions, and put the subjective refractions in trial frame, and then ask the patient to fix the near target and 8 line by N8 line, because the patient's fix an acuity N6. So always we give the one line above for the target, and then put the lenses in 0.25 diopter in both eye binocularly, and then ask the patient, can you see this line clearly? Patient says yes. Then put the 0.5 diopter in front of the in trial frame, and then remove 0.25 diopter. Okay, and ask the patient, can you see clear? Patient say yes. Then again put the 0.75 diopter in trial frame, and then remove 0.5 diopter, and then patient says now it is blur. And after reaching this point, ask the patient to instruct the patient to look at the line for the distance charge. He or she is already read earlier during the subjective test, or if the patient read 6.6, give the 6.6 target. If patient read 6.9, you give the 6.9 target. And at that time patient says I am seeing blur, and you perform the defog binocularly in 0.25 diopter stage until the patient reports when this line is visible again. Okay, and if you actually perform the Borish delay test, you cannot need to perform the cycloplegic refractions, because your answer of the Borish delay test is you same as you get the answer in cycloplegic refractions. That's why this is the strongest test. And for the relax somebody's accommodations. And next test is a modified Borish delay subjective test. This test is the same principle of Borish delay test, but some changes is occurs in this stage. This test, this test is for the accommodative spasm patients. What we do in a modified Borish delay, for first perform the subjective refractive corrections, and then perform the objective refractions, and put the subjective refractions in trial frame, and put the NRA value in trial frames, and ask the children to look around in waiting area, and also to do for the near activity 30 minutes. For example, if the patient subjective correction, you get the subjective correction is +1 diopter, and our normal expected NRA value is plus 2.5 diopter. So put plus 3.5 diopter in trial frame, and ask the patient to uh, do the near activity for 30 minutes. In initial stage, patient is not able to read for directly 40 centimeters, so encourage the patient to read for longer distance. And then after 30 minutes, ask the patients to look the distance visual acuity chart, and showing the largest optotypes, and was binocularly, and then perform binocularly defog in 0.25 diopter steps. And after patient seeing clear, perform immediately retinoscopy under the stable accommodative conditions. If still the retinoscopic is fluctuating, then you perform the monocularly fogging and defogging, and then you perform retinoscopy. And the sign of pseudomyopic is fluctuating visions, myotic pupils, and fluctuating retinoscopy. Here one thing is, remember, in the normal clinic we perform the retinoscopy in 2 minutes, and then we write the prescription. But in this case we not going to fast, because when we going to fast, we miss some important findings, like retinoscopic reflex is bright to dull. And okay, so take some time and then perform the retinoscopy. And esophagia tendency and very different manifestations on the cycloplegic refraction. And so after perform all these tests in accommodative spasm, what result is come up? Patients having a low MEM value, so the lead of accommodations, and low NRA value, and fails the monocular and binocular accommodative facility with the plus lenses, because the patient's lens is also having a plus power. And esophoria due to the accommodations and convergence increasing. And after what advise the management by the practitioners, pharmacological reduction with strong cycloplegic, such as atropine. As we all know, the atropine is used in both diagnosis and management. And milder cycloplegics like homoatropine in tapering the doses, and give the reading aid, because the patient is not happy with the patient is not able to see the clear near vision because of the cycloplegic effect, and give the vision therapy exercise. And sometimes the combinations of cycloplegic and vision therapy is better. Okay, and in here the cycloplegic dose of cycloplegics and vision therapy is also different to patients, according to patient signs and symptoms. As we all know, we all are comfortable with the with the cycloplegic drugs, so I am not going in detail about the cycloplegic drugs. So the available cycloplegic drug is atropine, scopolamine, and homoatropine, and cyclopentolate, and tropicamide. And you all are know the what is the side effect, like nausea and vomiting and fever, etc. Here we take one case from this article. So the first case is a 14-year-old male has a complaint of chief complaint of blurring of distance and near vision, and along with the headache and pulling sensation around the eye for the past 20 days. And in first examinations, patient's visual acuity is 20 by 200 for distance, and the patient's near visual acuity is N36 in each eye, and patient's non-cycloplegic retinoscopy showed say -7 with -1890 in both eye, and then examiner put the cyclo 1% cyclopentolate in patient's eye, and after the dilatations, patient uh, retinoscopy reading is +1 diopters spherical in both eye, and visual acuity, unaided visual acuity under the cycloplegic effect is 20 by 25 in both eye for distance, and near visual acuity N6 with plus diopter spherical lenses. An examiner prescribed at 1% atropine eye drop to be used at bedtime for the 6 weeks, and for the comfortable for near work prescribed the reading glasses under the consent of the ophthalmologist, and he asked the patient to follow up after the 8 weeks and the 2 weeks after the stopping the atropine eye drops. And in the second visit, the patient's visual acuity is the same as the first visit, is a 20 by 200 in both eye, and 6 prism diopter isodeviations, intermittent isotropia for distance and near. You can see here the ocular, no any documentations of ocular alignment in first visit, but in second visit 6 prism diopter isodeviation is present, and binocular visual acuity of the patient is 20 by 159, and here the visual acuity take on the logmark chart with the patient's complaint of the intermittent doubling of letters, and monocular visual acuity was 20 by 200 in each eye for the distance, and near visual acuity at 10 centimeter for near, and the patient is not complaining of double vision because we occlude the his or her one eye. That's why the patients only operate the divergence is not here present. And non-cycloplegic retinoscopy is -5. You can see here the fluctuating reading is come up here the -5, and in our first visit patient refractive error is -7 with -1 at 90°. And the dynamic retinoscopy is the lead accommodations, and after perform all these stages, the patient finding is lead accommodations, and examiner find and confirm that this case is accommodative spasm case, and then examiner perform the modified Borish delay subjective test, and after the both follow up these reading is come up. The in first visit patient's visual acuity is 20 by 200 in both eye, and retinoscopy under is both eyes -7 with -1 at 90°, and cycloplegic refraction is +1 in both eye, and post cycloplegic visit patient's visual acuity is same as the first visit, and retinoscopy is fluctuating reflex, and in MEM result is lead of accommodations, and in Borish delay subjective test give the answer in distance phase is plano, and visual acuity is 20 by 80, and in the near phase the patient's visual acuity is 20 by 25, and near is N6 with the plano, and then perform the retinoscopy under the stable accommodative condition is +20 +50 diopters spherical. And the examiner give the advice for the patient to home vision therapy exercise and accommodative facility flippers with a plus and -2 diopter flipper, and for monocular and binocular viewing conditions. In starting stage, patient is not able to with the higher amount of plus power, so give the low amount of flippers, and otherwise you also either you give the same amount of high amount of flippers, but you give the large print books, near vision book, and another exercise is version exercise with the broke string accommodative flippers, and this broke string and HART chart. In HART chart asks the patient to hold the near vision chart near chart at 40 centimeter, and put the distance chart at 3 meter distance. In starting stage, patient is not able to see, so give the 1 meter, then increase the distance, and time is increases, and 2 meter, and then 3 meter. Ask the patient to read first line and the near vision chart, and then see the distance chart, and then read the second line of the HART chart on distance. And here our the second case is based on the current scenario of COVID-19. So how we manage this case, here the patient is 10-year-old child and complain of headache and eye strain, and patient's mother notice inward deviation of the eye at the end of the day, and history of use of mobile phone and laptop 5 to 6 hours a day. And the previous checkup is 6 months back, and patient diagnosis is emmetropia. And in first follow-up, patient's reading is like this, and vision of the patients in right eye and left eye is 612, and after blink patient's vision is 6 parts. And auto refraction reading, here we take a 3 reading because to getting the correct answer of refractive error. The first reading is minus 1.5 with minus 0.25 diopter at 20, and the second reading is minus 1.25 at minus 5 with the minus 0.5 at 20, and third is minus 0.75, and in the left eye patient's reading is minus 1, minus 0.75, and minus 0.50. And in dry retinoscopy, glow is variable, fluctuating glow is seen, and in subjective refractions of the patient is minus 0.75 diopter vision, and patient's vision is 6 in both eye, and near vision is N8 after the blinking, and the near vision is N8 on blinking with a continuous focus. And examiner perform other additional tests, and in FORIA test patients having a distance orthophoria, and in near 8 prism diopter isophoria. In accommodative facility test performed binocularly. In accommodative facility is a 3 cycle per minute, and patients take a time on the plus side. So here our normal, according to our normal value is 11 cycle per minute. Here the patients having only 3 cycle per minute. And NPC and NPA is the normal, like 6 centimeters, and the cycloplegic refraction of the patient is plus 1 diopter spherical in both eye. And after finding all this perform all these tests, examiner confirm the diagnosis. This is a pseudomyopic patient, and examiner give the advice to the patient, no use phone for the at least 3 to 4 days, and again ask the patient to follow up for after the 5 weeks, and we give the home vision therapy like HART chart and cake cards and proc strings. And in second follow up, patient's vision in both eye is 6 clear, and N6 is in near vision. And auto refraction, so the minus 0.25 diopter spherical in both eye, and patient's dry retinoscopy is plus 50 diopters in spherical in both eye, and patient subjective except subjective refraction, and he accept the plano in 6 vision both eye, and accommodative facility 7 cycle per minute on our expected value side increased. So here the patient's accommodative facility is 7 cycle in our first follow-up patient having only 3, and patient FORIA is in 3 to 4 prism for near. And then examiner give the advice for the continue with your patient's HART chart exercise and gait card exercise for 1 month, and ask the patient to follow up after the 1 month. And examiner explain visual hygiene related to the screen time with the parents, because the child is not able to remember all those things. So how we manage the screen time during this scenario of lockdowns and COVID-19. So not all screens are equal. The large screens are better than the smaller screens, because a smaller screen produces some more eye strain. If possible, kids should work on desktop with proper lighting and postures, and reduce the brightness, and increase the front size of the laptop screen, and cast the online classes on TV for the elementary kids. So always invest your money on the smart TV than your tablets and phone for the better comfortable visions and eye. So remember to blink while staring the screen, and school should ideally schedule is 20 to 30 minute online classes, and then take a 10 to 10 minute rest break and in between the classes, and enforce the child to break between the lectures, and don't allow the children to continue the suffering of internet and chatting during the online classes, and on school days. Don't try to fill the day with screen based extra activities and all other things, and follow these easy golden rules: no mobile phone and unsupervised internet time on social media for younger kids, and no screen time for the children younger than 2 years, and make the screen time productive, like you watch the documentary and start an art project, and take a virtual museum, and make a YouTube video and etc. And keep the device out of the bedrooms at the night to maintain a healthy sleep pattern, and switch off all devices at least 1 hour before the bedtime, and no screen activity for the children. You find those games which your child like or enjoy, they like puzzles, and learn new cards games, and listen the audiobooks rather than the read book on the screen. And any other other game is also available, and exercise together. According to WHO, the children need 60-minute exercise per day, and adults need 30-minute exercise per day. So do the exercise every day. And if you have a terrace and garden or open area, encourage your child to go play, and and you also play with them, and there is a strong association between the patient and screen time. Therefore the kids interact reducing the patients and child face to face interactions and family time. So be a role model, put your phone away, and increase the face to face interactions with your child, and follow the 2020 rule. Every after the 20-minute verse, you take a 20-second break and see the 20-foot away object. So don't stress about the patient school work, and child school activities and all other learning activity, and your conference calling with your grandparents, because child needs some social connections with more. So give the all informations with parents, and if your and if and give the all instructions to your patients. So this is all my references, and special thanks to my sir Nirav Mehta and my senior Sivani Kansara. Thank you for the joining all participants, and for Optom team. Now a questions time.
Okay, now so moving to our discussion part. There are no questions we have got as of now, so we can wait for some time. Priya.
Okay.
If anyone having a question, please ask them in the chat section. Okay, Priya. So I think there are no questions from the audience.
Okay, okay.
Okay, so please share your experience about the ForOptom e-learning program for students.
Okay, Krishna. It is my first presentations with an ForOptom program for student. It is a good platform for student uh, to give the some knowledge with other persons. And so the thank you. I would like to thank you for Optom to give me this opportunity. So thank you so much for Optoms.
Okay, so Priya, one question we have got from Amrita Vicky. She
Okay.
wants to ask for pseudomyopia case, what type of specific visual therapy is beneficial for the patient?
In pseudomyopic patients, we give the accommodative flippers and HART charts and Kate cards, and these all are for the pseudomyopic patients, and drug string also.
Okay, thank you, Priya.
I hope your doubt is clear.
Okay, so I think we are done with our questions now. So we can end the
Okay.
session. Thank you, Priya. On behalf of the ForOptom team and our audience, I would like to thank you for sharing your knowledge with us and for this beautiful presentation. And also thanks to our audience for being supportive as well as interactive. On this note, we will end the session. Thank you.
Thank you. Thank you.